Dr. Theodoulou, you have the floor. Thank you very much for coming and sharing this information with us.
Absolutely. Thank you, Roberta. So as you stated, I am the chief of podiatry here, and our specialty is focused on lower extremity disease processes. That includes injuries, deformities, medical problems. And when it comes to particularly with deformities and what we would consider quality of life type surgeries, our world has evolved, particularly in orthopedics, trying to employ newer techniques and technologies that minimize the surgeon's presence in repair of these deformities. And it's nothing unusual. Many specialties have evolved in this when we consider the use of robotics now, general surgery with laparoscopic, endoscopic techniques, our vascular surgeons who are doing more things endovascular versus open bypass. It would make sense, again, in orthopedics that are there ways we can correct disabling presentations, deformities in a way to minimize the, as I would say, the footprint of me as a surgeon correcting these deformities. And the benefit of actually doing that is that we can actually get our patients to heal faster. We create less swelling, less pain, and we can restore them back to life in a more expedient fashion. And yeah, in particular in our older population, as we get older, we do have some compromises of our tissue. So if I can minimize my injury, so much the better. Plus it gets our patients up on their feet faster, gets them back to their activities. And what I've found in practice myself is my 70 and 80-year-olds now are far more active and participating in sport. Our goal is to return people to activities. Humans were meant to be on their feet. We're bipedal species. We were designed to be walking and moving and going from point A to point B. The fallacy that's been out there, I believe, is that as we get older, we need to slow down. And, in fact, I would say the opposite. We need to keep moving more than ever. And the first thing that comes in contact with the ground, as Roberta rightfully said, is the foot. And if there's pathology of the foot, then the challenge of staying upright and moving becomes a big problem. And as a podiatrist, as a specialist in this part of the body, initially my primary treatments is to try to manage these conditions conservatively. Can we modify shoes? Can we do local padding? Can we do some type of supportive brace or device? Because ideally that has the least downtime for a patient. If I can keep them moving and do this in a conservative fashion, fantastic. We avoid the downtime of surgery, we avoid the risk of surgery, and we keep the patient going. So all treatments, particularly with these types of quality of life deformity issues, are treated non-operatively with education on footwear, activity, commonly if it's painful, judicious use of non-narcotic analgesics, physical medicine and rehabilitation. All of these are big aspects. But there are some deformities that persist and remain painful and really do impact our patients. And so as time has evolved and we've grown in surgery, we've tried to limit our impact in recovery, and this is minimal incision surgery. So traditionally, we would make large incisions to expose bones and in particularly bone deformity correction, and bunions is a huge issue in our society. It's been estimated that 2 million Americans seek out care for bunion deformities in the United States on an annual basis, and that may be a small number. And so it's a very commonplace deformity. Its presence oftentimes is related to genetic or familial disorders, but it can also be induced by footwear or worsened by footwear. And it creates challenges for many patients to be comfortable in their shoes. And so when we get older and we don't want to expose our patients to large reconstructive procedures, but simply to relieve that bunion presence, that bump, can we do less invasive techniques? And this minimal incision surgery approach seems to be ideal for that. So you can see in the in the photo on the left, traditional surgery would commonly require a good 6 centimeter linear incision over the skin. We would dissect through all of that, and we would create our exposure to the bone, do whatever work we needed to do to reduce the deformity, but all that needs to heal.
Michael, I apologize for interrupting, but we're still on the first slide.
Yeah, I haven't moved yet.
Oh,
so
okay. I just wanted to make sure. Okay,
yeah.
good.
And on the right, what you can see is kind of our, what we call keyhole incisions, where we can actually execute and correct these deformities through much smaller incisions. And by doing so with less dissection, less trauma, less swelling and recovery, and in fact, less pain. And so what you can see on these x-rays and this clinical photograph, here is a correction or a presentation of a bunion deformity. And through minimal incision technique, we can actually create these osteotomies, as you see, and we can restore the anatomic alignment without causing major trauma. Traditionally, you can see on the right, an incision for correction of bunion on a younger patient in their 30s that we did a more aggressive surgical intervention. And you can see the scars. And on the left, what you can see is a 75-year-old who underwent a percutaneous or minimal incision type technique for correction of the bunion through small little keyhole incisions. And you can see the unique difference and you can imagine the expedience and recovery that takes place. The surgery that we do is in the operating room has some specific approaches that we do. We make, again, small little keyhole incisions in order to introduce a burr so that we can affect the cut in the bone. We use small guide wires, again, through small keyhole incisions to secure the cut bone into a corrected position. And we apply our orthopedic screws to stabilize the bone. This is where the real evolution of minimal incision surgery, particularly for this deformity, has come along. In the 1980s, we experimented with this type of surgery, and we were doing it in a fashion that may not have been the best. We didn't have the orthopedic screws or techniques to help stabilize these corrections, and many of these patients had notable complications. But as more experienced surgeons who have done traditional surgery, open approaches, and appreciated anatomy embrace this again. And with the newer burrs and engines that help us create these bone cuts and the newer screws that we have available, we've been able to re-engage this approach in a newer generational technique, what we would call minimal incision 3.0, so to speak, and employ what has been always traditional orthopedic fundamentals in healing of bone osteotomies and bone cuts in this minimal invasive way. And in the operating room, I'm going to try to get us over to an animation so you can kind of get an understanding about our approach to doing this. I'm going to see if I can give us. I'm going to go ahead and play this so that you can kind of appreciate the technique that we do to employ this correction.
Arthrex presents a minimally invasive.
And I'm going to shut off the volume and I'll speak over it. So this is the bunion deformity. It is actually a deviation of that long metatarsal bone that we're marking out currently, and the great toe or the proximal phalanx. And what we have found is that as the long metatarsal bone deviates towards the midline, the great toe will move towards to outside of the foot or laterally. And so our technique is to make a small stab incision. We elevate the tissue off the bone with a special instrument. And through that small stab incision, we can introduce a rotary burr. Now, what's unique about the instrumentation we have now than compared to the 1980s is that these burrs are what we call lower speed, higher torque. And from a surgeon's standpoint, the importance to that is when we had higher speed burrs, these would actually burn the bone and potentially produce risk of non-healing bone and non-union. With the new engines and motors that we have available with slower speed, higher torque, we can more efficiently cut the bone and make the appropriate cut to correct the deformity. And essentially what we're doing is translating this bone into a corrected position. And once we do that full osteotomy, as you see, we can rotate that bone in multiple directions. We'll provisionally stabilize this correction with a wire that you see us introducing in this animation out the end of the toe. And you'll appreciate what we can do with this. We can now shift the bone over into its corrected position and stabilize this segment with this wire temporarily. And this wire will be pushed backwards and we'll have the correction that we're trying to achieve. Now, the nice thing is in some areas in geography, some people believe this wire is actually the fixation that the patient will have in their postoperative recovery. And there's a rationale and basis for it. But what we have found is that if we introduce orthopedic screws, again, through 2 small keyhole incisions, we have a better maintenance of correction and stability in the healing process. And so what we'll do is put 2 guide wires in this fashion to allow us to drill over these guide wires and introduce the orthopedic screws that will maintain the correction of the deformity in recovery. And there's no pins exiting the skin. Those little stab incisions are closed, and you have no worries about a pin exiting the skin. And so what you'll see us here in this animation is make those little stab incisions in the skin. We'll introduce our devices for measuring the length of the screw and then drilling over this segment. And what we'll have is a stable correction of this osteotomy and correction of the deformity. And what you can see frequently is once this is over, you can see that little overhang of bone that persists. Some surgeons will go ahead and remove that overhang. Most times what happens is the bone simply remodels over time and that overhang is not an issue. But we can come back in and do that. Now, oftentimes in correction, I told you a second component of the bunion deformity is the great toe. So it's not just the long metatarsal bone, but it's also the bone of the great toe. And we'll perform in a similar fashion a keyhole incision and make a little cut in the bone like this, as you can see with this animation, and straighten the toe out into a more corrected fashion. All of this is again done through just a minimal incision percutaneous approach to correct the deformity. And you can see the reduction and then the placement of the screw. We measure again. And so when all is said and done and the correction is completed and the screws are in place, and I'll take us through this, we can see that we have this corrected deformity and we've restored the alignment of that entire bone segment without creating much trauma to the patient. The nice thing about this approach is the recovery aspect of it. Historically, we would put our patients in a large bandage or a cast to allow the tissue in the bone to heal. But now essentially all we're doing are small little taping, little wound closures and taping to help maintain the alignment of the toe in correction and minimizing big casts, immobilization, disuse that we speak of, that patient's not functioning on the foot. And the typical recovery for one of my patients with this type of bunionectomy is we give them a hard-soled surgical sandal for about 2 weeks. Depending on the amount of swelling at 2 weeks, sutures are removed. And if there's not much swelling, I actually will return my patient back into a sport or athletic shoe at 2 weeks, commonly no later than 4 weeks. Most of our patients can return to light intensity activity by 6 weeks, which means high-speed walking, stationary bicycle. And for the majority of my patients who may be runners, I get them running back no later than 12 weeks. You can consider in the traditional surgery basically doubling that time. So what we're done with this type of approach is we've had the healing time associated with the bunionectomy that we do. And I'll take a brief moment there if there's any questions with regards to this type of approach for fixing bunion deformities?
I just want to ask, is there any animation? We're seeing stills. Are we
Oh, I'm
supposed to
sorry.
show-
So the animation is not coming through.
Right.
My apologies. Let me see if that was animated. So all you were seeing were stills through that process.
Right, we're seeing stills.
Let me see if I can speed one through for us a little bit, and you can tell me if you're not seeing stills. Let me get back to where I was. Let me close that. I'm going to watch again. Let me see if this is presenting as a still or a video now.
Still.
Single stills, huh? Each still that's coming through, you can kind of see it come through a little bit.
We have just the still pictures that we're
Right.
looking at.
We're still in the slideshow.
You're still in the slideshow, so you're not. So let me see I said new share. Let me see if I can do this as a new share. I apologize. Let me see if this will do it for us. Can you see this now?
Yes.
Okay, so let's take this quick. So I spoke through it. So this is the presentation of a bunion. This is the deformity that we see through, if you could see through the skin. We appreciate the long metatarsal bone, and we appreciate the proximal phalanx of the big toe. Through a keyhole incision, we will create a bone cut. We use a special elevator to raise the tissue off the bone. And then we will use this special burr that I spoke about with its engine to make the corrective cut in the bone. And I can speed this up a little bit. And we'll make our corrective cuts. And we can translate this bone over. Can you see that okay?
Yes.
So we can push this bone over. We'll provisionally stabilize this with a little pin. We'll get it corrected to where we want. And we can use our guide wires to place orthopedic screws to hold the bone. This is what makes this uniquely different in this approach. We'll commonly make another cut in the great toe to help realign it in a similar fashion through a keyhole incision, make our osteotomy, reduce that, and again, put a small screw to hold that, so that what we end up with is a correction of the deformity, as you see. And that is all done through small stab incisions. The benefit, again, as we say, I'm going to go back to my new share again. The benefit of that is actually our recovery process. So we're not putting large bandages in place. We're more expediently returning people to activity and getting them back on their 2 feet with correction of deformity, resolving their pain. And as I said, particularly in our older population, it makes a big difference. So now that you've seen that animation, unlike before, happy to answer any questions if anyone has that with regards to this type of technique or approach in fixing this deformity. Excellent. So bunions are a very common process that we see, but we also see, not infrequently, what people are very familiar with are hammer toe deformities. These are digital contractures of the toes. They cause pain and impingement on shoes, and they can be very challenging for individuals to wear shoes comfortably, particularly some sport-specific shoes. And again, we encourage a conservative approach to this, but when that fails and patients have tried to modify their shoes, digital padding, again, appropriate anti-inflammatory medications, then surgery is an appropriate course. And historically, what we would do is we would make, and as you can see in the center picture, rather large incisions over the toes. We would make these incisions cut down to the bone and the joint through tendon. We would correct the bone and remove necessary bone to straighten out the toe. And then we would exit the toes with these wires that would stay in place for no less than 4 weeks and up to 6 weeks. And for many patients, having wires sticking out of their feet isn't an ideal situation. No one's comfortable with that. There is risk for developing infectious process because of the exposed wires. It definitely slows down the healing time because we are leaving these wires in place. And so in a way, again, to get people back on their feet in correction of this deformity, we've approached this in a more minimal incision technique. And if you can look at the x-ray on the left with those screws in place, those are the small orthopedic screws, not so dissimilar to the bunion surgery, that we introduced to stabilize the toes into a corrected fashion. And again, we do that through a minimal incision approach. And what I'll again try to do, and if I can do this appropriately, is I'm going to go ahead and see if I can share again my screen with you, looking at, let's see if I can pull this down a bit. Looking at the approach that we do this through an animation of hammer toe correction in an animated fashion. And I'll bring this back so that you can see this a technique. So what you can see on the
Minimally
screen.
invasive approach to hammer toe to correct it.
So what you can see on the screen is that what we appreciate is the hammer toe deformity, the digital contracture that you see that occurs to the joint. We'll make a small keyhole incision through the joint, and we'll go ahead and introduce a burr to plane the joint and remove our cartilage surfaces so that we can straighten out the toe. Through that small keyhole incision, we'll introduce a little drill so that we can pass those screws that I showed you on that last x-ray. And we do that in the proximal toe, the proximal phalanx, and we'll do it out the end of the toe, again, drilling through the bone. Again, this is all done through that 2 to 3 millimeter incision and not the large incisions. We pass the wire that we would traditionally leave in place and maintain the correction of the toe for a few weeks. But now this wire really serves as a guide for us to introduce those orthopedic screws to keep the toe straight. The benefit again about this technique is the screw stays in place, so correction is permanent. The wire, which has to come out in 4 to 6 weeks, it no longer has efficacy because it's no longer there. And so we maintain this correction over an extended period of time. And so, one, the approach is much more simpler. We do less trauma. 2, the screw remains indwelling, so the correction is sustainable. And 3, because of the minimal trauma associated with this, we return our patients back to activity and footwear in a more expedient fashion again. So, as you can perceive, these deformities that have become kind of nuisances and challenges have really, through these minimally invasive techniques, allowed us to correct them, minimize the downtime, and get people back onto their feet. And you can see the amazing corrections that can be achieved through this small incision technique. I show you this because now we not only doing these corrections through the front part of the foot, but we are also doing this to correct deformities in the back part of the foot. And it's not uncommon for us as foot and ankle surgeons to deal with some pretty complex deformities, collapsed feet, extremely high arched feet. These are all frequently driven by deformity that involves the heel and the ankle. That used to require large incisions, a lot of trauma to restore the alignment of the foot and the ankle. And now, again, through this type of percutaneous or minimal incision technique, we can actually do these restorative alignments on our patients, again, in a very minimal fashion. This x-ray is a patient of one of ours that we did just last week. She had a collapsed foot, what we call, in lay terms, many people will suggest a flat foot, but we really appreciate that it's not really just a flat foot when it becomes a problem like this. It really is a collapsed foot where ligaments and tendons fail. And a big component in restoration and repair of this deformity is actually to correct the alignment of the heel bone. And to do that, we actually have to cut the heel bone and introduce orthopedic screws. Well, in the past, I used to make large incisions over the outside aspect of the heel. In that area, there's some vital structures to include nerves that would not with frequency, but can develop scar tissue and have residual nerve pain and problems in that regard, and even sometimes wound healing complications. And so if we can engage again through that keyhole incision, that 2 or 3 millimeter incision, an ability to make a cut into the bone and restore the alignment, push the bone within its tissue envelope without fully exposing it, and then stabilizing it again percutaneously with orthopedic screws, this makes a great difference. And so again, I will take us to an animation that I have that can show you this approach that we do now in correcting this type of osteotomy. And we'll play this for us. And you can kind of see the approach that we.
Calcaneal osteotomy through a minute.
So what you can see is this is a foot that the heel has rotated out from underneath the leg. And traditionally, what we would have done is made an incision over those lines that you see, or that white line being drawn. This is the geography, so to speak, of where we make our bone cuts. And through this, we make a small keyhole incision again along the side of the bone. We again utilize a tissue elevator to help elevate this tissue, both inferiorly and superiorly. And again, utilizing one of those special rotary burrs, we can actually make a cut into the bone. Now, we teach surgeons to kind of cut the bone in a quadrant type fashion, where we'll make cuts, as you see here, 1, 2, 3, and 4 to complete this perfect cut through this small incision. But the cut is completed as being shown here. And so we'll go up, and it's a sweeping motion that we use. We'll take it to the next quadrant, make a sweeping motion up as well. And then in a similar fashion on the bottom half of the bone, make a sweeping motion down, and then on the other side. And once this is done, we have a completed bone cut that allows us, not unlike what we did for the bunion, the metatarsal head, to actually essentially realign the entire bone segment to restore the alignment of the foot. We'll put a small elevator to help shift the bone over for us. And then we use those same types of guide wires that I showed you in the past to secure the correction and fix the deformity. Again, by doing it this way now with this approach and technology, we've really minimized the healing time and a lot of the secondary risks associated with surgery. Foot and ankle surgery is very challenging because we have a plethora of nerves and vital structures in a very confined area. And if we appreciate the anatomy and where those vital structures are, and we do our work in what we call safe zones, and not have to make large incisions and expand the presence there, we really reduce the risk of these secondary problems that was oftentimes frequently seen in open traditional surgery. And again, for our patients in recovery to these types of processes, healing is dramatically faster. We don't have to keep these patients in casts for extended periods of time. We get them up on their feet much faster. That reduces the risks of what we call disuse weakening. It reduces the risk of blood clots because we can move them that much faster. And so what we're trying to do is produce also a safer surgical environment for our patients.
Well, this is Amazing. And there's so much information to take in. A couple of quick questions, Dr. Theo. For the minimal surgery,
Mhm.
can you do both feet at one time?
Excellent question. Yeah, so yeah, in fact, we do. This is one of the benefits because patients can wait there on this type of surgery, particularly the bunionectomy. Historically, we would only do 1 foot at a time in more traditional approaches just because of the trauma, the immobilization, and all of this that goes with it. Now with minimal incision technique, because we're really trying to get our patients back into a sport type shoe as soon as 2 weeks, it is appropriate for us to consider both feet at the same time. So patients only have to go through one anesthesia event, one operative setting. Patients are far more accepting of that, and it makes a big, big difference. It's hard to want to get somebody to go through all the trauma of surgery and say 6 months later, guess what? You get to come back and do it all over again on the other foot. So if there's means like this, absolutely. So if both feet are involved, both feet are causing problems, the ability to do what we call bilateral surgery is in this realm of minimal incision surgery.
So do people go under general anesthesia or local for this?
Yeah, so that's another fantastic question. With this approach, actually I have colleagues and in many parts of the world, in Europe particularly, but even the United States, many of our patients are doing this in an in-office operatory type clinical setting and doing it under local anesthesia. Personally, the majority of patients that I do with this type of approach is done under what we call monitored anesthesia care, where my anesthesiologist will give a slight sedative, make the patient feel comfortable. I'll give a numbing block to the area to give. Okay, so yeah, so with this, we do this more under a sedation, local anesthesia type technique in our operatory setting, and we do it very comfortably like that. If somebody really wants general anesthesia, they can have that. A lot of times, again, we'll do this through a laryngeal mask versus intubation, unless there's medical reason. But for the majority of these patients, this can be done under sedation with local block or straight local block. The other nice thing about why this can be done that way is in traditional surgery, we'll frequently apply a tourniquet to limit bleeding to the surgical site. That tourniquet has an effect. It creates a bloodless environment, but it does create almost a toxic bloodless environment, to say no better word for it. It produces ischemia. We're cutting off blood supply to the part while we're doing that surgery in correction of this deformity. Now, we don't have typically complications with that, but we have found, and there is literature in my own experiences, that patients where we use a tourniquet typically have more pain acutely postoperatively. They may have some more swelling postoperatively. So this surgical technique, minimal invasive, because we're not making large incisions, I don't employ the use of a tourniquet. We don't see a lot of bleeding with it because we're not making large incisions in trauma. And so we avoid the need of a bloodless field. I don't mind a little blood with this. It doesn't affect us. And we mitigate the complications of a tourniquet, which is increased swelling, increased postoperative pain. I will tell you, it is not uncommon in my postoperative course for MIS surgery. My patients take no narcotic analgesics. They'll take maybe an ibuprofen or a Tylenol or something like that, again, because I haven't caused surgical trauma worthy of a narcotic. And in today's environment and our concerns about narcotic use, this is absolutely conducive to this type of non-opioid, limited postoperative pain type process. Now, that's not to say people don't have pain, and there are some, everyone's unique, and there are some people that we have, in fact, prescribed narcotic analgesic if they need it, but a vast majority really get by with something like Tylenol and ibuprofen in recovery to this approach.
One more question can you talk about the angular cyst correction? Angular cyst, articular cyst, sorry.
Articular cyst, correct. So I don't know exactly what they're speaking of, other than, if we're speaking about a cartilage injury that can occur to joints, or if we're talking about cysts that can develop behind joints that we see in degenerative arthritis or even with articular damage. And so I need a little more specificity with that. But I can.
I'm not sure. Maybe the person will put in the particulars in the chat. That was just a general question.
So, I mean, articular cysts, let me help and maybe define this a little bit. When we speak of articular surface, that's the cartilage surface that lines the ends of bones that come together to form a joint. In damage to that articular surface or that cartilage, we can see underneath the cartilage, cysts become to develop. And interestingly, again, in the percutaneous approach or minimal incision, if it's in the ankle, let's say, that I frequently get involved with, we're now doing arthroscopic approach. And in fact, our arthroscopy now is done with a needle inserted scope. That means the diameter of our scope is about 1.9 millimeters. We're approaching the size, essentially why they call it needle arthroscopy, the size of a needle. So again, we're making small keyhole punches. In fact, we're doing it through a needle inserted technique, putting a special fiber optic camera in there now, evaluating the joint directly, again, with this small fiber optic camera. And with smaller instrumentation, again, we can actually start treating the cartilage damage and the cysts that develop. In fact, what we've begun to do, and this is maybe a future topic for us to talk about, Roberta, is we've embraced regenerative medicine, where we actually harvest bone marrow aspirate from our own patients. We spin it with a special device that actually can separate out the cellular content of that aspirate, get growth factors and stem cells, mix it up with tissue and inject that into the cysts to produce a healing process and to begin to reverse the arthritic damage that occurs with these cysts. So it is a variation of minimal incision surgery that we do, utilizing needle inserted arthroscopy to repair these damaged cartilage. So this is kind of another discussion. I try to focus on bone deformity today, but this is also something that we do for joint disease or joint pathology for sure.
So this is incredible. We've come a long way. And would PT be required for the minimal surgery?
Yeah, it depends on the individual. You know, a lot of the reason we needed physical therapy after the traditional surgery was because of the scar tissue that was created by the surgery, and to mobilize that scar tissue. And also because patients were restricted in their physical activity for more extended periods of time. And so there was a lot of disuse, what we call disuse weakening. I don't believe in not using something. I don't believe in abusing something. I believe in good native use of a body part, even in recovery from surgery, is absolutely critical for healing of tissue and limiting all these factors that we were dealing with in more traditional surgery. And so traditional surgery really demanded it because of scar tissue from surgical trauma. If we have less surgical trauma and not the scar tissue, a lot of these patients' range of motion immediately after surgery is 100%. Wow. Is absolutely 100% with no restriction whatsoever, and because we're only keeping them off their feet maybe 1 or 2 weeks at best and trying to get them back into tennis shoes by 2 weeks, and we have less swelling, a lot of these patients don't demand physical therapy. That's not to say that we don't send some of our patients, but a lot don't demand it because we haven't inflicted the injury of surgery on them to the same degree.
Amazing. Well, we could keep you for about 3 weeks, but we won't. But there's just a clarification on she meant to say articulosynovial cyst in toes is what she was asking.
Oh, ganglion type cysts and things like that. So yeah, those cysts, ganglions or mucoid cysts of joints, is an outpouching of the of the synovium that cause fluid accumulation. This is the typical ganglions or synovial cysts we see. Interesting thing we do with that now we use ultrasound guidance in the clinic a lot, and we'll use an ultrasound to evaluate those cysts. And with ultrasound guidance, we can introduce a needle and aspirate those cysts, again, through a minimally invasive approach. These can recur with that technique, and sometimes they do require surgical excision. But an initial attempt with ultrasound guidance of an insertion of a needle right into the cyst, drawing the fluid out, has worked very nicely. And sometimes we'll introduce some cortisone in the area afterwards.
So how do we get to you? You are a surgeon, and typically you're a referral from a primary care physician?
Yeah, so we get, what's great, we have a wonderful CHA patient population. We have a wonderful primary care network that refers to us. I'm blessed in that I'm known to do these types of surgery, so I have a lot of outside referral that is driven by industry somewhat. As you can see, some of those animations are actually with the company that I work with the minimal incision type technique, and they have a website that actually sends patients our way. But at Cambridge Health Alliance, the surgical scheduling number is 617-665-2555. It's myself, and I have two other wonderful partners that do foot and ankle surgery similar to me, Dr. Harry Schneider and Dr. Jennifer Buchanan. Dr. Schneider is the director of our residency program here at Cambridge Health Alliance, so he stays very busy in that leadership. And Dr. Jennifer Buchanan is a former resident that we brought on and have been very fortunate to have her, as she's the future leader, as she's a bit much younger than me, and is extremely well trained because we trained her, and does these surgeries very nicely as well. And so all three of us would be happy to participate in your care, but they can call that number. Primary doctors can refer into the Department of Surgery, as they frequently do, and patients can have access to us.
Well, thank you so much. This has been, you are a wealth of information, and people are grateful for the information that you've shared. Thank you so much. And join us next month. And we'll be going to talk about breast cancer awareness for next month. And it will be the first Wednesday as usual. So thank you so much for your time, Dr. Theo. And thank you everyone for joining us. Take good care. Stay safe, everybody.
Thank you.